We've got a fantastic lineup of speakers, our guests, very prominent leaders in the community, which I'm sure are going to indulge us with a lot of information. I know I'm going to learn a lot today, so I'm sure you guys out there as well who are listening are going to experience the same. But what we always do is we always ask you to join us. It's inclusive. We want you to call in, talk to us, ask questions, offer your comments. And in order to do that, you can come forward and give us a call on 0116 4822 086. Or if you want to send us a text, then you can do so on 077 488 or email us on info@ramadan.fm. We are also live streaming on YouTube and also on Facebook as well. And we also have a Twitter account on at Ramadan Radio. So you have all options of engaging in any which way you find comfortable. But yes, let's do that because we've got a fantastic lineup today and a very, very interesting topic. Now, what I'm going to do is I'm going to introduce you to my speakers. I'm going to start off by introducing our first speaker, who's very well known, and I will say, and I'm proud to say, a good friend as well. He's no other than our Professor J S Bamrah, who's a senior consultant psychiatrist and chair of the British Association of Physicians of Indian origin. He's a writer, researcher, and lecturer. And I did ask JS, please forward me your intro, and I think he's been very modest to leave it to that. I could go on and on. I think we could have a full show on that. Good morning and Sat Sri Akal and Namaste, JS.
Good morning, Adab and Sat Sri Akal, Namaste, Shahid. I look forward to, and my good friend Salman, of course, you know, this is a pleasure.
Of course.
And I just want to, just while I'm here, wish everyone happy Ramadan. And Ramadan, of course, is a festival that embraces all those virtues that are so dear, isn't it? About reflection, about prayer, about community work, about fasting, you know, making sure that in mind and body we are clean and clear. So happy Ramadan to all your viewers and listeners.
Thank you very much, Jayas. That's very kind of you, and we're absolutely spot on what you say. And our second guest today is another good friend and someone who works tirelessly and has been working tirelessly for as long as I've known him, is always on the go. And it's no other than Dr. Salman Waqar, who's a general practitioner in Berkshire. And he's also a research fellow at the Nuffield Department of Primary Care Health Sciences. He's also the General Secretary for BIMA, which is the British Islamic Medical Association, and also the coordinator of the BAME, which is Black and Ethnic Minority Groups Health Professionals Consortium, and sits on the NHS Chief Police Officers Clinical Advisory Group. And I'm witness to the work that Salman and JS have both done for the BAME Health Professionals Consortium. And it's not just work that's been done, it's work that is ongoing. And hats off to both of them. And that's one of the reasons, because of these credentials, not only their previous qualifications and the work that they've done, but the work that is ongoing. So welcome. Assalamu alaikum, Salman.
Walaikum Assalam, JS, great to see you again. Happy Vaisakhi to you, a bit belated.
Thank you.
But, it's nice how it's all come together, hasn't it? A lot of our festivals have merged in the same time, unfortunately under lockdown, but here's hoping to a brighter future. But thank you, Shahid, for the kind invitation and the ever so kind introduction, but look forward to our conversation.
The pleasure, Salman, and it's lovely having you both here. Right, so we've got a lot to cover, and we want to talk about today racism in healthcare organizations, challenges. Well, I would say ask the question, does it exist? And there's a reason why I asked that question. It's because of a recent report that came out. There is some historical factors here, and I'm going to open up the floor to both JS and Salman, because it goes back a long way with the number of reports. And maybe very briefly, JS, starting off first, if you can sort of touch on, just to give us a little bit of historical perspective of where things have been and where they are now.
So Yes, I think racism, discrimination in its many colors has been plaguing our societies, as you're aware, for a very long time. And I could go into endless reports there have been 14 major reports that have been commissioned by these governments, the UK governments. And we're all responsible citizens, as you're aware, but none of those reports have come to anything. And this is the tragedy of it, you see. So racism is neither to be seen nor to be heard is really the mantra. What has happened during COVID, of course, it has brought all of it to the fore. It's shone a very bright light on all these discrepancies and discrimination. And if you see the history of how this has developed, you will find that in that order, Black communities, Bangladeshi communities, Pakistani communities, Indian communities, Chinese communities, mixed race communities, in that order, have been very severely affected. What happened, however, last year was two things happened. COVID-19 happened, and Black Lives Matters happened. And those two are the issues that we're concerned about.
JS, I think you've just gone on mute. JS?
Oh, have I? No?
Oh, no, that's better. We've got you back.
Okay. Oh, sorry. Must be my internet. So I was just saying, sorry, I don't know how much of that was muted, but I was just saying that it's all culminated in two major events that happened last year. One was COVID-19, which shone a very bright light on the ethnic disparities and social determinants of poor mental and physical health. And the other was Black Lives Matter. And I'm sure you would come to that. Black Lives Matter was the reason why the British government, the Tory government, actually commissioned this Sewell report that you referred to earlier.
Thank you, JS, for that succinct but very useful intro, if you like. Salman, is there anything that you would like to add to what JS has kicked off with?
Yeah, I mean, I think it's important to remember, this isn't new. Any of these concerns, any of these findings. I'm not as long as the tooth as the both of you, and you probably know more about the reports that have come out beforehand, particularly around the medical profession, the Fair to Refer report, amongst many others. There's lots of issues around differential attainment in postgraduate education, reports of discrimination and racism when it comes to appointments for consultant posts and other senior manager posts. So we're dealing with a situation that isn't new. As JS has said, COVID has been something that has brought a spotlight onto it alongside Black Lives Matter. But those of us who have been in this space have been experiencing this for many, many years, some as long as their careers have existed in the NHS. And what we now have is an opportune moment to try and do something about it while the spotlight is still on us. Of course, we have to contend with other forces that see and think otherwise. And perhaps that's something that we can talk on in our discussion today.
Absolutely, Salman, and we most certainly will. And let's just park that one as to what are we going to do? What is happening, what we're going to do? Just carrying on from the historical perspective. Now, let me start off by something that I've heard, and I'm sure you may have experienced it yourself in the healthcare organizations, something that you must have heard a lot of individuals from the Black and ethnic minority group talking about, and that is, you have to work harder. It's unlikely you're going to get shortlisted. Why don't you change your name? Maybe a better or higher probability that you'll get shortlisted. And then we look at healthcare NHS organizations where you see 30, 40, 50% of the employees from the ethnic minority. And then you look at senior management where it's a bit of a disparity there. And then you move even further higher where you look at the board level. And you'll be lucky if you see one or two from the Black or ethnic minority in many organizations. So, JS, what would you say about that?
Well, look, all of that is true, and I think you have to understand that there are a number of non-believers in all these issues. There's been a lot of research. I can refer to medicine particularly. So the first report that came out in the 70s was a report by Everington and Ismail, Whereas I think Salman was referring to that, or you were referring to it just now, which is that Anis Ismail swapped his name with Sam Averington, and Sam Averington, who was Anis Ismail, got more interview selections just after they had graduated from medical school, absolutely opening up a Pandora's box of how discrimination affects medicine. I'm afraid not much, and I'm sure both of them would agree, both of them are very dear friends of mine. Not much has changed. In fact, in some areas, unfortunately, this has got worse. So, as Salman was referring to the fact that you were saying we've got to work harder. Of course, we have to work harder. Definitely. You know, your CV, I find people burning, you know, their camps on both sides, wanting to do more in order to show that, particularly when they come from abroad, from India, Pakistan, Sri Lanka, Africa, that sort of thing, they feel obliged to demonstrate that they're twice as good when they shouldn't have to do that. And when they get their CV through, they're less likely to be interviewed. And once they're interviewed, they're less likely to be selected for the job when they're equally competent as white colleagues. And many white colleagues would actually agree with this. A recent report in racism in medical schools by the BMJ and BMA also demonstrated that there is a high risk of people being racially abused and bullied even in medical school. So this is quite a major thing, really, that has been going on for decades. You know, when I came to this country from Tanzania, from Africa, nobody would give me a job. For 2 years, I was servicing petrol pumps and working in corner shops. So, you know, for 2 years, just out of my house jobs, it was a tough time. But look, we're here to talk about solutions as well.
Absolutely, yes, which we will come on to when we get to the second part of our show after the break. Thank you, JS. Salman, you mentioned earlier on the word differential attainment, which links in very well with a lot of work that's been done, but specifically to another report which was also been commissioned by the GMC not long ago, about 3 years ago, 2019, by Roger Klein, which also touched on a lot of other issues related to differentiation in referrals to disciplinary processes, whether locally within organizations, to the GMC, and issues related to fitness to practice. Obviously, this stems off from the Bawagawa case, which many people would have heard of. Just as a starting point, Salman, can you just sort of, so that viewers understand what is actually meant by differential attainment, and in this particular theme or context, what it actually means?
So the term is used to describe the disparity that exists between white and non-white trainees in the medical education system. And so what we have seen for a number of years, particularly in the specialties where we have a large number of Black and minority ethnic doctors, is that the white colleagues are performing better than their non-white colleagues. And the reasons for that, they struggle to explain as to why that is. JS and Bapia have done some phenomenal work, and it's probably best if he comes in on the exact nature of this. But just to go back on perhaps the earlier conversation that we were having, I think it's important that people recognize that what was happening to JS when he moved over from Tanzania were people having to, you know, it's atrocious to have someone who's highly qualified coming into this country as an economic migrant, being able to contribute a lot to an NHS that is severely understaffed and underfunded, being forced to work in the petrol stations. That, I would imagine, is not happening. There may be isolated cases, but the type of discrimination has changed. It's no longer overt. No longer people are saying it to your face that, you know, I won't employ you because you don't fit in, or because you're brown, I won't employ you. The nature of the discrimination now is more structural. It's more subtle. It's more, it's difficult to pin down, which is why it makes it so troubling for us in this space who want to see these movements actually having not got much further or having it arrested at a point. So, for example, when it comes to differential attainment, just to jump back to this point, one of the reasons that they posit is that actually, if you look at the data, if you have the white postgraduate students as the standard, below that you then have the BAME graduates who are British born and British trained. Below that you have the IMG, so the international medical graduates, who perform the worst. And if you add a gender on top of that, females perform better than males. So if you're a male overseas graduate, you are more likely to fail your exam than someone who isn't. And then when you say to them, well, what is the reason for that? They struggle to really give us any sort of factual or solid evidence. One of the possible reasons is because when it comes to the communities of practice that are formed when people are training, when you're looking for patients to review, when you're having education that is not part of the formal curriculum, so offline, after the lectures or after the seminars, a lot of those are around how people gel and get along with each other. And if non-white groups are finding it difficult to access those communities of practice, they will then be isolated from that educational experience. And certainly from the Muslim perspective, a lot of Muslim trainees tell us that issues around alcohol and socialization, for example, is a barrier to them. So you're not really going to see that when you look at the data, but then you go away and ask people, what are the reasons, why are you finding it difficult, or why is it such that you're not getting the same marks as others? These are some of the things that are coming out. And this is where the structural issue comes into play. It's no longer naked discrimination, because the process by which people are recruited are now thought to be blinded. There is still a lot of unconscious and in some cases conscious biases and structural issues that exist in the system.
Thank you, Salman, for clarifying that and for our viewers to understand what that actually means. Structural racism. JS, what does that mean?
So it is, as Salman was saying, this is differential attainment is part of that. Structural and institutional racism are issues that have plagued the NHS for a very, very long time. And what has happened is that within the system, there is that very subtle noise that, you're an underachiever, not because of any other thing, but because you've either come from abroad and you've come from an inferior university, or it is based on the country you come from. They may not specifically say that you're brown or black, but some might say that. Some might say, well, your thinking is different. You don't think in the English language. And therefore, because you don't think in the English language, English is not your first language. There is implied in their criticism that you're kind of sub-intellectual, and some would go on to say worse things than that. And of course, differential attainment is, and Salman is right, we started a year-long project on this last year, which will conclude in the autumn this year, Papio, which looks at all of this. And, differential attainment is just a part of that, which is that your ability is considered to be based on your culture or your color, rather than your achievement. And that's the sad thing about differential attainment. Famously, of course, come to light in 2014 when Papio took the RCGP and GMC to court over particularly BME doctors not passing the MRCGP, the college exam, which makes you a GP. The judge said at the time that it was a legal defeat, but it was a moral victory, because there was a recognition by many people, including by the then chair of the RCGP, Claire Gerarda, who then afterwards said, yes, some parts of the exam should be scrapped because they are discriminatory. And and structural racism, exists in the way society is, for instance. Why are people in overcrowded places? They will criticize people for being overcrowded.
JS, I'm gonna come back because we're just going on to a break.
Yeah, sure.
And what I'm gonna just, if you can just hold your thought there, because this is really important, and I just want to carry on because of the whole issue related to COVID, etc. So we're going to take a short break. You are listening to Ramadan Radio 87.9 FM, and we're going to go for a short break, and we'll be back and see you on the other side. Ramadan Radio. I'm your host, Dr. Shahid Latif, and you are listening to Ramadan Radio 87.9 FM. As always, we've got two very esteemed and very knowledgeable guests, and the topic that we're discussing today is basically racism and discrimination in healthcare organizations, but also in a wider perspective as well. And that's what we're going to be streaming into in the next 20 odd minutes, 15 to 20 minutes. We would like you to, and we would love you to join in. We've already had one message, which I'll just touch on. But before we do that, how you can join us is by listening to us on 87.9 FM, or give us a call on 0116 4822 086. Comments, questions for our two guests. You can, or if you are not willing to come on and talk, then send us a text on 0774 88 55055, or via an email on info@ramadan.fm. And we are running live on Facebook and YouTube, so you can see both of our guests there as well. So we've got Professor J S Bamrah, and we've also got Dr. Salman Waqar. So just following on, there's something that you touched on, JS, but before we go there, we had a message about an unfortunate incident about a young student, Muslim student, who was in a very esteemed institute in London, Barts as we call it, and unfortunately, because of the challenges that she experienced wearing a hijab, challenged by her line manager and seniors, she actually had to leave the profession and went into another profession, which is very sad indeed, based completely on wearing hijab. So just before we come on the topic of unconscious bias, J.S. Salman, do you want to, I read out the whole text to you, do you want to give your views on that? Is that something that we hear a lot of?
Unfortunately, yes, and my heart goes out to the sister, and I'm sure that there will be much reward for her for her perseverance in trying to put up with those bullies. The text was quite long, and it went into some detail about some awful situations. Unfortunately, gendered. There's always this issue of intersection. So when you have different characteristics which are not part of a majority, and you put them together, the likelihood of you experiencing discrimination and the type of discrimination you experience accentuates. So there's a concept known as a triple penalty that particularly affects visibly Muslim women, and particularly if they're Black. So if you have those three characteristics, so if you're visibly Muslim, you're a woman, and you're Black, you are going to experience the worst forms of racism and discrimination in any workplace. And there's lots of evidence. There's a report that went out to, I think, one of the select committees in government that highlighted that. But particularly this issue, because this sister raised the point around wearing the hijab, and particularly in surgery, this is an area of work which we know has been a huge issue. Why should a person's choice of dress, particularly a religious dress, which is perfectly acceptable, it's nothing outrageous, it's just a piece of cloth, why should that stop people from carrying out a career that they want to do? The case that you described is an example of where there's been some naked and very aggressive discrimination, but there are still lots of cases today of women being harassed, being given subtle hints, being told that they don't belong in spaces just because they're wearing the hijab. We've been trying to do a lot of progress in this area, and perhaps we can come back to some of the solutions later, but it is unacceptable, and it should definitely be something that if anyone is experiencing in 2021 any form of discrimination regarding their dress, their religion, their gender, that they speak out. There are plenty of organizations now, there are plenty of allies in this space who will be able to help you and will be able to make sure that you can carry out your career and the job that you want to do to the fullest extent that you want to do it. But, it's such a terrible story, and I really hope we get to a space where this never happens again.
Absolutely, Salman. Couldn't agree with you more, and I'm sure most of our speakers, or all of our speakers, I hope, would agree with what you've said. Jay, is it something that individuals from other religions, from the Sikh background, Hindu, Christians, Jews, is it something which is experienced as a wider thing, or is it more Muslims because it's the hijab, I suppose, is being a female, as Salman has said, or is this a wider problem where we get even, people adorning the turban, the pug, as we call it? Is there an issue there as well?
Well, I think, it is as Salman was saying, if you look a little bit different, we are a Tesco society. Every tomato has to be round, it's got to be red, it's got to have no blemish in it or any changes in it, it's got to have a little green leaf on top of it or a couple of green leaves. And society, British society, has been modeled in that way. So if you look in any shape or form a little bit different, such as the hijab, which she has another, she's a great pioneer. I wish she were still in medicine at the time of COVID. She'd have been doing great work, isn't it? What a big loss it is. What a big sacrifice for her and her family. I think we should be ashamed that, in society, that something like this can ever happen, that people are hounded out of their job, not because of competency, but because of their cultural beliefs and that sort of thing. So yes, around COVID, there were the usual thing about Sikhs, Muslims and Jewish people, men having beards and PPE not being fit for them. And, one Sikh friend of mine said to me that he was asked to cut his beard. Well, people should be sensitive to these sorts of cultural beliefs, And of course, people don't retaliate. We have a lot more support. The network that Salman has so kindly formed and puts a lot of energy into that. I wish that were available in 1997 when our caller actually were wearing the hijab. We have so many organizations now, BAME organizations, that are mutually supportive. But unless that message, and you remember that 40% of NHS doctors are actually from a BME background. Nearly half of us are from a BME background. There is, for the NHS to increase its productivity, is really to be aware that, that sort of racism cannot be allowed to continue. So yes, there are so many cases like that, people being called names, stupid names as well. There was a case of a Nigerian patient, it's in the BMJ, that this was a white surgeon, and he said to his white trainee, you're not operating on bloody Nigerians here, you're operating on a human being. So this is in the BMJ, by the way. So there are many stories like that that put shame into medicine.
Disgusting, to say the least, isn't it? I'm going to come back. So you touched on something which is COVID and PPEs and deaths and frontline workers, etc. But before I do that, some of our colleagues, counterparts could say that this is unconscious bias. What's unconscious bias, JS? And is it unconscious bias? How does that work?
Well, I'd be the wrong person to answer this question because I've been arguing with many people, including the proponents of unconscious bias, that you can't have any bias if you're unconscious. If you're unconscious, you're kind of half there, half dead, aren't you? Kind of loose language, I say that. So really, it's either conscious, unless we bring it out and say it's conscious bias, we're not going to. I think unconscious bias gives legitimacy to people's conscious bias. And I would really sooner that the whole idea of unconscious bias were ditched. I was called to the Royal College of Ophthalmologists. They did a seminar around this, and they were going to run a course on unconscious bias. And I hope I managed to persuade the president, Bernard Chang, that look, unconscious bias isn't what we should be talking about. We need to talk about discrimination, straight. Of course, we all have prejudices, Shahid, you know that. But we don't play out our prejudices in such a way that it affects another human being. We keep them in our head. We all have our little biases and prejudices, but we don't actually play them out. When we play them out so that it disadvantages somebody, it's discrimination. And to my mind, that is plain. I'd be interested to hear what Salman says, but I'd say that is complete, plain conscious bias.
Yeah. Thank you. JS made that loud and clear. And Salman, just following on from that, along with what JS is saying, some of the things or some of the issues, and I know for a fact, being on the Equality and Diversity Steering Committee with the Royal College of Psychiatrists, and some of the words even there being used like unconscious bias, we've advocated to have those removed and talk more about issues about leading on to the consciousness and some of the solutions for this. And historically, over the years, we've been talking about things related to cultural competence, which seems to be like a tick box exercise where you spend the afternoon going through a module training program, and you're supposed to be culturally aware. And the next terminology which is coming out, or which is more favored, I suppose, is cultural intelligence, a bit like emotional intelligence. What are your views on that, Salman?
Yeah, I mean, just to follow on from JS's point, I think it's important people realize that the unconscious bias, on the unconscious bias issue, the police in America, someone did some stats, JS, you probably may be familiar with them. They've had like millions of hours of unconscious bias training around Black people. And yet you still have, disproportionate arrests, murders, deaths in police custody, despite all of that. So, I think I would agree that, it's a tired term, and it's a time we thought about things differently. And it does also speak to this issue around how our context frames our content or our presence, especially when we live in a very media politicized world where the media and social media, particularly the bubbles that we have now, the echo chambers that we have in social media and WhatsApp and Facebook and so on, they inform, or in many cases misinform, our perceptions of reality and of others, particularly if we don't interact with those groups. And I think we need to make an active effort to make sure that we are reaching out to these communities, and that applies to all of us. And that kind of touches on this point around cultural competence and intelligence. So, as you said, Shahid, cultural competence traditionally is in a sense of, yes, I know that the Muslims have this thing called Ramadan. I know that there's this thing called Vaisakhi that the Sikhs have. I'm vaguely familiar with the 5Ks of the Sikhs and so on. So there's a knowledge tick box as it is. But we all know that knowledge is not that useful unless it's applied. And this is where the concept of cultural intelligence comes into play, whether you are able to apply that knowledge into different contexts, and you're able to actually step into the shoes and step into the communities which you are talking about. So you're able to essentially navigate the spaces in a much more lean way, and therefore also come across more authentic, and not come across as someone that just rocks up for a photo when your colleagues are having their iftar and then never seen again. You're aware of the language, you're aware of the nuances, you're aware of the challenges, if we're talking about institutional barriers that these communities face. And that, unfortunately, for a lot of us in a lot of our colleagues in the management sphere, does mean more work for them. It's not a simple exercise to just turn up and shake some hands and go away. It is a continuous process to continually engage, continuously read up, continuously be reflexive and reflective as practitioners. And that's one of the things that I think would be quite vital for us, to not only have our emotional intelligence, cultural intelligence, as people of faith, have spiritual intelligence alongside our intellectual intelligence as well.
Thank you, Salman. That's very comprehensive and understandable, I suppose. And some of these things, I just wonder, is it common sense, and are we devoid of these common sense? But thank you. JS, earlier on, you mentioned COVID, PPEs, deaths, frontline workers, BAME, 40%, 90% deaths, 95% BAME. How does that all work? How did that happen?
I know it's such a blot on the NHS, isn't it? But it's not the NHS, really. I think this is just, our hearts were sinking at the time when we were looking at the statistics. You could see they were just dropping like flies, unfortunately. 95 to 97% of doctors who've died so far have been from a BAME origin. 70% of nurses who've died have been from a BAME origin. Amongst the professionals, and even in the community, high risk of getting into ICU and getting the severer end of COVID and dying from COVID. So we know that elderly in care homes and BAME communities were the most affected, sadly. and politicians were very, I mean, Bapio wrote on the 6th of April to the Prime Minister then, saying the first 11 doctors who died have all been from BME origin, and what are you going to do about it? I think there was just, and then gradually people were saying, well, it's not because of ethnicity. There is this idea which floats around that ethnicity is not a factor, when there is clear research to show that it is. Ethnicity is a factor. There are issues to do with how BME people live in deprived communities, about their jobs. Most of them are likely to have labor jobs which are not regular jobs. Most of them have had to go from places to places in order to make a living because they couldn't be furloughed. There are so many complicated statistics buried within these sad deaths. The government has been slow to recognize that COVID deaths in this section of the community have been down to institutional and structural racism. I can't put it as anything else, Shahid.
Yes, unfortunately, yes. And with all that background and context, and then we get this report by the Seal report, Tony Seal, which was commissioned by the Race and Equality Disparity, following on from the BLM. Following on from BLM in the situation which we had movement. Salman, just briefly, I mean, because I know we're going to be talking a little bit about solutions or attempted solutions. Seal report, I mean, obviously it says that there's no such thing and it doesn't exist. And it's very clearly stated that it's more down to socio-economic, due to cultural, religious reasons why individuals have experience, and those are the barriers rather than there being any institutional racism. What's your thoughts on that?
So it's a shame. It's a missed opportunity because of the attention that ethnicity and as JS said, and you said as well, Black Lives Matter gave to this. It was very much on people got it, or people seemed to get it for the first time, or got the extent of the problem for the first time. It is, in the letter that we wrote, so with, I think it was about 45 different organizations, BIMA, BAPIO, the APNE apps, the Pakistani organizations, it was really across the board, Filipinos, Nigerians, Cameroonians, Sikh doctors, lots of people were involved in that. Unanimous in our view that this, if adopted, so as you said, Shahid, the thinking behind the report, or the recommendations in the report, are to say that Britain is doing a great job when it comes to ethnic communities, and what we now need to focus on is the individual, not the structural issues. If we go down this road, we are going to end up dismantling, defunding, deprioritizing any initiatives that actually seek to redress any structural systematic issues, and instead fund, resource, and prioritize interventions that seek to focus on the individual. And now, when there is a huge corpus of evidence, international world-leading experts like Professor Michael Marmot at the UCL Institute of Health Equity, and many others who have said that they don't stand by the findings of the report, even though the report cites their own data, are saying otherwise. There's a huge danger that this is going to end up harming our communities further. The crux of the matter is that despite there being one or two aberrant pieces of data that may suggest otherwise, the overall, the enormous body of evidence that suggests otherwise is far too difficult to ignore. And it seems very convenient that the data that have been presented have been cherry-picked. And these aren't our words, these are words of many others, academics and people in the political sphere, to support a narrative. The key issue here is individuals like me or you, or our communities that we're part of. We do have agency, of course, but that agency is limited in the context that we're in. As JS has said, if you have got the name Sam Everington, you are far more likely to be invited to interview. It doesn't matter what the culture of your community is. It doesn't matter if you drink, Guinness and you, do all the things that the rest of society do. The fact that your name is different, the fact that you come from a different culture, means that you're not going to be treated the same. So regardless of how much agency you and your community have, there are still structural barriers. And this has been consistently demonstrated through countless reports. And the sad fact is that if there was some data, and of course as scientists, we recognize that the truth is always open to interpretation. We're always looking for, different perspectives on things. But what this report did was go beyond that. It went beyond simply stating there is no structural racism. It then went to say that those people who deny it are being unpatriotic or are somehow pulling Britain down. And that's where it goes far beyond an academic piece and very clearly into something else.
Yes, unfortunately. We've got a number of messages coming through. Obviously, I'm not going to have time to go through all of them. I mean, they're talking the similar things about hijab, about fasting, about discrimination, about bullying, etc. We've got a little above 3 minutes left. And what I really want to do is just give you both an opportunity. Starting off with JS. What are the solutions? What needs to be done?
So, a student report is going to be a major thing for the government. And I come from an angle that one of the best things that happened to us was the student report, because it suddenly got many major organizations such as NHS providers, a lot of statutory organizations denouncing what it has said. So the way forward is, I'm afraid, it's going to be more campaigning. The government is not convinced that there is institutional racism. Michael Marmot, who is the guru of all social determinants, the disparities that exist in community, has come out plainly and said that there is structural racism in society. I think we need to continue that campaigning. We need to educate our colleagues. We're not carrying banners going there telling people. Maybe that's what should happen to 10 Downing Street. But certainly that campaign is going to continue. What we need to do is people have been saying, look at all the 24 recommendations that Cyril has made, and because they're going to implement them and decide what you're going to do. Well, I'd rather that it was buried, but if it's not going to be buried, maybe people like us need to look at them and engage in whatever shape or form. Otherwise, we will see the worst excesses of the report being implemented.
Yeah.
So yes, more work to be done, Shahid, and we're there. We're up for it.
Absolutely, JS. Absolutely. And we've got about 1.5 minutes. Salman, would you add to that what JS has said?
Yeah, I think it's we are working together. COVID has brought us together. The Cyril report will bring us even closer together outside the medical sphere. Lots of organizations want to be part of an alliance to really put forward, what we feel is the right step forward. We're having conversations with the medical hierarchy. JS has been championing it for many years, but I think, we're on the cusp of something here with the regulators, with the trade unions and so on. So I guess it's really a case of watch this space. Yeah. In terms of some of the other issues that you mentioned around the hijab, BIMA have done a toolkit. So any healthcare person or in social care who has issues around wearing the hijab, please check out that website, britishima.org. There's some great resources on there. And also, if you do have issues around discrimination and bullying, the British Medical Association, BAPIO, APNE, BIMA, these professional BAME organizations also have very active chapters within them who can also help individuals overcome issues.
Listen, I can't thank you both enough for coming on today. You've touched on some excellent points, and not only for coming on today, but I want to say personally to both of you, Salman and JS, thank you very much for all the work that you're doing, and I'm sure you're going to you've done it, you're going to carry on some of the things you've touched on. So thank you very much, and it's much appreciated. And we will call you again, maybe in the future, to see where we are, and I hope we've made some inroads. You've been listening to Radio Ramadan. We've had Dr. J S Bamrah and Dr. Salman Waqar who've joined us. Thank you very much for all your comments, and it's been very enthralling, and we will see you again next week. Assalamu alaikum.